Good evening, everyone. I want to thank Dr. Saunders for that lovely introduction, really appreciate it. And I'd like to thank Dr. Mukadam for reaching out and inviting me to be here today. And also Dr. Ajrouch for graciously hosting me this afternoon and showing me around the Baker Public Policy Institute. It was fascinating. I am just thrilled to be here. Very excited for many reasons. One is because this is in celebration of National Arab American Heritage Month, and I think that's a very exciting, development in the U.S. to even have a month that recognizes the contributions of Arab Americans to American society. But I'm really excited to talk about my topic, which is a social lens on Arab health in the U.S. And one of the reasons that this topic really excites me is because as a sociologist, I am very committed to making clear how important social aspects of our life are to who we are and our health and our well-being. Oftentimes, social things aren't taken very seriously, and I think it's because they're hard to see. They're hard to touch. You don't really know what these social things are, what these social elements are. And that's one of the reasons why bringing them to light, I think, is an important first step in really understanding why social elements of our life have such a huge impact on our health. So I want to begin by talking, I want to sort of highlight what has been said about Arab American Heritage Month. This was President Biden's proclamation at the end of March in 2023, where he said the Arab American story is the American story of one of diverse backgrounds, faiths, vibrant tradition, bold innovation, hard work, commitment to community, and stalwart patriotism, all coming together to accomplish something greater than any one of us. And then he talked about the significance of it for all of the contributions that Arab Americans have made to the U.S., including all the professions that we find them in, and how integral they have been to the United States. But what was also noteworthy in his proclamation is that he said, sadly, we also recognize that even as Arab Americans enrich our nation, many continue to face prejudice, bigotry, and violence, a stain on our collective conscience. So I wanted to point this out to note that it's very exciting that Arab Americans are being recognized and the heritage that they have are being recognized for the contributions they're making to the society in the U.S. But I also think it's important to point out that it's also recognized that Arab Americans are also oftentimes discriminated against and treated unfairly. So what I want to do today in my presentation, my short time with you, is to talk first, why does race and ethnicity matter in the U.S.? And I think this is such an important point. You know, my son just got married in December, and he married a young woman of Lebanese ancestry. And I'll just tell you, I'm half Lebanese, half Iranian. People always want to know what my Middle Eastern background is. So my son married someone of Lebanese ancestry from Australia. And they got married in December, and she immigrated here to the U.S., and now she's looking for jobs. She's filling out job applications. And she said, they're asking me what my race is. What do I put? And so my son had to tell her, well, you're supposed to put white, because legally Arab Americans are considered white. She's like, but is that what I am? Am I white? And this is a significant situation for me to tell you, because it really illustrates that race and ethnicity is just such a foundational element of how U.S. society is organized. And it's, again, one of those things that's hard to see, not necessarily hard to see in terms of what race a person is, because we're socialized pretty well in the U.S. to know how to differentiate races. But it's hard to see what effect race and ethnicity has on people's life experiences. And so I want to talk about the social determinants of health and why that framework is so useful for understanding people's well-being. And then after that, I'd like to share with you findings from two studies that I have led recently. One is what I'm calling the Metro Detroit COVID study, which sampled adults age 65 and older in the Metro Detroit area who were Arab American, Black, and white, to look at the stress from COVID-19 and the effect that it has on cognitive health. And then I want to tell you a little bit about a project that I led to adapt an existing Alzheimer's disease caregiver intervention to make it relevant to the Arab American community, and in that really faced issues of stigma, which I'll talk a little bit about. And then I'll end with some conclusions and future directions. So why does race and ethnicity matter in the US? So in the United States, there are 5 legally recognized racial groups and 1 legally recognized ethnic group. Anyone know what the legally recognized ethnic group is? Hispanic, Latino. And the 5 races are white, Black, Asian, American Indian, and the Pacific Islander. These racial categorizations have deep historical origins on a global scale, but I'm just going to focus about the historical origins in the US context. Our domestic policies of slavery, colonialism, and citizenship are what made race so salient in the US. And I just want to, in terms of citizenship, the US began counting race in 1790. So at the very beginning of what we know that is the United States today of our history. And why? Because they wanted to be able to know who they could give citizenship to. And race was one of those foundational elements. US citizenship was granted only to free white persons who were residing in the US for at least 2 years. Now, race and citizenship. So this is very relevant for the Arab American case. As you may know, Arab Americans have been coming to the US for centuries, starting in the late 1800s, early 1900s is when they've been documented. And in the early 1900s, when there was a heightened level of nativism in the US, it's so interesting because in the early 1900s, the level of immigrants that made up the US society was about 14 or 15%. It's the same level that we're facing today in 2023, where we're about 14 or 15%. And that's sort of when you get that nativist reaction from the general American public. So in the early 1900s, heavy nativism. They didn't want immigrants here. They thought they were ruining the country. And in that case, they were really upset about the Catholics coming here because it was strictly a Protestant country. So this whole religious basis of not wanting people in your country is not new. We have a history of that. But in the early 1900s, we had immigrants who were primarily coming from what we would call Greater Syria, at that time, which included present-day Syria, Lebanon, Jordan, and Palestine. They were coming to the US, and they were termed as Asian because they were coming from West Asia. Well, if you were Asian, you couldn't get citizenship. So there were, and some people did get citizenship, and then it was revoked from them. So they had a whole series of cases that ultimately led to a court decision that said anyone who comes from that part of the world, from the Middle East, would be considered white. Now, I want to make clear that it wasn't always smooth sailing. There was a lot of contested cases over the years. But pretty much what this signaled was, first of all, how whiteness was going to be defined, which included not just those of European ancestry, but those of Middle Eastern ancestry. But it also signaled to those immigrants who were coming from the Middle East that you're supposed to identify as white. And that was a big watershed in terms of our history. And it's really interesting because now, as you may all know, our communities are agitating for a shift where Arab Americans don't want to be white because they don't feel that they're treated as whites are treated, and I'll get to that in a minute. So if you filled out the decennial census in 2020, you saw, this is just an illustration, you have to fill out the ethnicity question first, and then you go and you answer the race question. What was significant about the 2020 census is for the first time, they had write-in boxes for every single racial group. And so what's really exciting is the census is going to be analyzing the white category so that we can pick out our Arab Americans and know something significant about them, hopefully. Although there's a lot of problems with this methodology because it's voluntary, but that's a whole nother issue. Now, what's going to happen, what the proposal is for 2030, and I don't know, this might be too small for you to see, is this having ethnicity separate from race, what they found is that there's an enormous proportion of Hispanics and Latinos who, when they get to the race question, they're like, why are you asking me this again? I already said I'm Hispanic Latino. So they check other and they write in like Hispanic or Mexican or Puerto Rican or whatever it is they are. So what the census wants to do now is combine race and ethnicity so that you don't ask the ethnicity question separately, and they want to add what we're calling a MENA category, Middle Eastern or North African. Some of you, did you guys hear about the request for public comment from the Office of Management and Budget? And I think the last day you could have done that was yesterday. So they're really rolling this out, wanting to change the way in which race and ethnicity is measured, because there's growing recognition that race is, well, first of all, let me just say that race is not a biological fact. It's a social fact. It's socially constructed. I mean, what makes someone white, what makes someone black, what makes them Arab, what makes them Latino as an ethnicity? These are all definitions that were created by people to designate. I mean, I want you guys to think about the world. If you go from Africa, the southern part of the hemisphere, and you start moving towards the equator, people start getting lighter, right? And then you go above the equator and people start getting even lighter. At what point do you stop and say, well, these people are white and those people are black? It's arbitrary. And what geneticists have shown is that 99.9% of our genetic makeup is the same. There's 0.1% that differentiates us across races, and as a matter of fact, there's more genetic variation within these so-called racial groups than between these racial groups. So I want to make that clear. It's a social fact. It's not a biological fact. And just like you're seeing the creation of this MENA category, it hasn't existed in our country for 200 years. But we're creating it now. It's a social fact. It's something that we're making. So when I refer to Arab Americans, and I want you to notice here that I'm also using the term Middle Eastern, North African, because that's the nomenclature that we're going to be saddled with. I'm not happy about it. I actually don't like that term. I think there's a lot of imperialism behind it, but that's a whole nother story. When I talk about Arab Americans, I'm referring to people who trace their ancestry to an Arabic-speaking country. Now, if you know anything about the Arab world, and I think many of you do, there's a lot of different Arabic-speaking countries. There are 22 that belong to the Arab League. And so when I'm trying to find Arab Americans for my research, that's how I define them. Anyone who traces their ancestry to an Arabic-speaking country, for my definition, will be Arab American. So that includes Assyrians and Chaldeans from Iraq. Now that's problematic for some because Chaldeans and Assyrians don't necessarily identify as Arab. But what we have found through our research is that people who come from that part of the country have very similar experiences here, no matter the fact that they're religiously diverse, no matter the fact that their nationality is diverse, no matter the fact that they're ethnically diverse, they have very similar experiences. And that's what race in the US is all about. It homogenizes a very diverse group of people and puts them into one category as if they're all the same. As I just mentioned, the Office of Management and Business legally classifies Arab Americans as white. I now sort of use MENA and Arab interchangeably because it's sort of what we're going to be facing, I think, in the near future. I will say one very encouraging piece of information is that there were a series of studies done on Arab Americans using the National Health Interview Survey. The only way you could identify Arab Americans in the National Health Interview Survey is whether or not they were born in the US. So they're only immigrants in the National Health Interview Survey. And so there was a series of studies done by some colleagues of mine who showed that actually Arab immigrants have worse health profiles than US-born whites, which is really interesting because if you guys have heard of the immigrant paradox before, which was primarily discovered on Latino immigrant samples, it's usually immigrants have better health, and the longer they're here, the worse health they have. But what we're finding with Arab Americans is the opposite. Arab immigrants have worse health and their future generations have better health. In this case, this comparison was only with US-born whites, not necessarily Arab American. Nevertheless, the point that I want to say here is that when we redid the analysis and defined the group according to MENA, because as you know, MENA expands the definition from not just Arabic-speaking countries, but it also includes Iran, Turkey, and Israel. When they expand it to those groups, there's still a difference. The MENA still has worse health immigrants than US-born whites. So there's something about coming from that part of the world that's important. Just a very quick migration history. I think it's important to note that, as I said, Arab Americans have been coming to this country for a couple of centuries, but there's two distinct time periods. One that I call pre-1965 and one post-1965. Pre-1965 are all those who came in the beginning of the 20th century. They're the ones who fought for the right to be white so that they could be citizens. They were primarily of Syrian and Lebanese origins. Immigration from that part of the world almost 100% stopped. There were still some who came after 1924, but the Johnson-Reed Act effectively stopped immigration from anywhere except for if you were from Western Europe. So for about 40 years, we didn't have immigrants coming into the US. That all changed in 1965. In 1965, immigration opened again. And this time, immigrants who were coming from the Arab world were coming from regional turmoil and political instabilities. And as a result, the origins expanded to include immigrants from Egypt, from Palestine, from Yemen, from Iraq, among many others. They weren't primarily only Syrian and Lebanese anymore. And what happened was that this is really interesting. Maybe some of you have heard these stories, but people who were coming post-1965 had heard about the community that existed in the Metro Detroit area in Dearborn. Now, those who came in the early 1900s and settled in Dearborn, they were going there for the automobile factories. There were jobs there. So they went there for work, they built a community around there, and then people who came after them, even though they may have settled in a different part of the country, many picked up and left and went to Dearborn because they knew there were others like them there. As a result, southeastern Michigan has a prominent and visible concentration of Arab Americans. As a matter of fact, the largest concentration in the country. Right now, New York State has the largest population of Arab Americans, but they're spread all over. There's not a visible community. California comes in third. Michigan is second. But Michigan has the most concentrated community there. And I just want to point out here that in 1990, according to and by the way, the only way we can ever identify Arab Americans in the census, and I'm going to refer to the census here, is through the ancestry question. I don't know if any of you are familiar with that. But there is an option on this annual survey that the census does for people to write in their ancestry, up to 2 ancestries. And so we can identify Arab Americans from that coding. And that's how I find my data when I'm looking at a national sample. So in 1990, less than 1% of people living in Michigan were Arab American. Almost 30 years later, they tripled to 3%. Now that may sound like it's not that much, but they're very concentrated in one area. So when you go to the community, you feel that you're in an Arab American community. And this is just to give you an idea of Michigan. So this is the Tri-County area down here. And here I have broken it up by the census data. 55% of all Arab Americans are in the Wayne County, and that's where Dearborn is. Lebanese are the largest proportion of Arab Americans at 34%. In Oakland and Macomb counties, which are quite a bit smaller, you have Chaldeans and Iraqis make up the majority in Metro Detroit. Okay, so the question is, okay, so we have Arab Americans coming to this country, so how do Americans feel about Arab Americans in this country? It's really hard to study that. Hard to study that because it's hard to identify Arab Americans. The one exception was a study that was done by a sociologist named Vincent Perillo, who did this project after 9/11, and I know you're probably all aware after 9/11, Arab Americans became hyper-visible, but in a negative way. And the social distance scale was developed by Emery Bogardus, who used to survey his students in his college classrooms to try to discern the extent to which students would accept people who are different than them. And the closest measure would be if you would accept someone who is different from you into your family by marriage, so you would allow them to become part of your family, that to him would signify that there's no social distance. You see that person as a human being, their race and ethnicity doesn't matter. And then it fans out from there. Close friend would be the second degree of closeness, neighbor would be the third degree. If you don't mind working with them would be the fourth degree. Speaking acquaintance would be the fifth degree. Sixth, visitor to my country would be sixth, and then seven would be I would bar them from my country. So Vincent Perillo did this in 2001 after 9/11, and he included two categories that had never been on the list before: Muslims and Arabs. And what he found, he also talks about just plain Americans, and they're the closest, followed by Italians, and then it goes down. Who was the last group? Arabs. Muslims not far behind. And I'm pretty confident it was because of 9/11 that this is why it happened, and this was back in 2001, but I do this exercise with my students every semester. Up until 2 years ago, I haven't taught this class in 2 years, race and ethnicity. Every single year I do it, Arabs are last. And it varies. Some of the data they collect has Arabs as 7. Others find themselves to be progressive and liberally minded, and they'll say 1 or 2. But so when you average them out, it doesn't necessarily, it's 1.94 is about 2, right? Well, that's because you're averaging it out. But a lot say 7, and nevertheless, Arabs are still the last ones that they feel closest to. So why is that? I like to draw your attention to the media. I'm not saying media is the only reason why people have this impression, but what comes out in my classes over and over again is that they don't know anyone who's Arab American. The only information they get about Arabs is in the media. And the media images are gendered. We usually have women who are either presented as belly dancers or as totally covered. And in both cases, they're considered oppressed because either they're overly sexualized or they're invisible. Men, when they're presented in the media, are either terrorists, oil sheiks, or camel jockeys. And that signifies violence, backwardness, and greed. So you have these negative images that have been around since way before 9/11. 9/11 is not when this happened. As a matter of fact, I would argue since 9/11 we've actually had some improvement, although not enough to counter the hundreds of years. There's a great book by Jack Shaheen, if any of you have ever heard of it, called Real Bad Arabs, and real is spelled R-E-E-L, where he documents all of the ways in which Arabs have been characterized in movies and television and everything in between. And the problem isn't even necessarily that it's negative images. The problem is that there's only negative images. There's no other image. So when you want to know who are Arab Americans, that's what you see. So this is drawing your attention to something social, right? So these larger contexts are the contexts in which Arab Americans are living in the United States. And I remember, and I'm sure many of you have these stories. I remember after 9/11 happened, my daughter was only 10 years old, and she was playing volleyball, and she was wearing a mashallah, a necklace, but she had to take it off for volleyball. And she lost it, she left it at the gym where she was playing. And I said to her, well, just ask the teacher. She said, well, what am I gonna say, that it says God in Arabic? She's gonna think I'm a terrorist. I mean, that's coming from a 10-year-old. So you have, Arab Americans coming of age, growing up in a society where they know that there's a negative feeling towards them. We need to measure this. We need to really study it. And this is one of the reasons why we need to find good ways to find Arab Americans for our studies. So this is getting us to the social determinants of health, right? Social determinants of health refer to underlying community-wide social, economic, and physical conditions in which people are born, grow, live, work, and age. Social elements affect a wide range of health, functioning, and quality of life outcomes, including disease risks like obesity, heart disease, diabetes, Alzheimer's disease. These social determinants are, as a matter of fact, when it comes to Alzheimer's disease, currently there is no cure. And the only effective way we know right now to deal with Alzheimer's disease is to find ways to reduce our risk, and that's through the social stuff. The diet that we eat, making sure we're socially engaged, making sure we challenge our minds, making sure we exercise. These are all social things, and oftentimes things that people don't pay much attention to because they just want that silver bullet. Just give me a pill so I don't get Alzheimer's disease. It's more complicated than that. What we know about these social determinants is that they're not randomly distributed, and they're inextricably linked to one another. So for example, education level impacts employment opportunities. Neighborhood location can impact healthy food options. These effects persist across generations and drive health inequities, especially those based on race and ethnicity. So I really firmly believe that by focusing on Arab Americans, we can advance the study of aging and health and really come to understand disparities. Arab Americans have been invisible in aging and health research. They are rapidly aging, however. This American Community Survey data shows that just in Metro Detroit, age 60 plus. So, more than 1 in 10. So they're a presence in our communities. We have very few data sources. The community studies that exist aren't very representative. If you partner with a social organization, they tend to serve the needs of underserved, of those who are in need, social and economic need. So it's a very biased sample. Plus it's a convenient sample, so you're not able to generalize it to all Arab Americans. Representative samples are oftentimes considered to be undercounts. I just told you about the immigrant-only option in the National Health and Interview Survey. The census allows us to identify Arab Americans, but they have very limited measures. We can't measure, for example, unfair treatment and discrimination in the census. We have very, very limited options. However, even though we have limited options, I do want to take the opportunity to just show you socioeconomic status as it relates to Arab Americans, and this is from the American Community Survey. The blue bars are Arab Americans, which I have labeled MENA here. The red bars are the non-Hispanic white population. And what you can see is, if you look at those with a college degree or more, and those who are unemployed, and those who are living in poverty, Arab Americans are doing pretty well. They have a much higher proportion of their population who have a college degree. They're less likely to be living in poverty. But I also want you to see this. They also have a higher likelihood of having people who have less than a high school education. So I like to refer to this as Arab Americans are really a bifurcated community. We have pockets who are doing really, really well, but then we also have pockets who are not doing well. And this is at the national level. So I was really curious to see, how does Houston compare to the US? Houston's doing really well. This is the US Arab American population. In Houston, you have a much lower proportion of people with less than a high school education, much higher proportion of people with college, less likely to be unemployed, less likely to be living in poverty. So just comparing Houston to the US, you see the Arab American community is diverse. Now I want to show you Metro Detroit, and I want to focus on Metro Detroit because that is where my research happens, and so it's important to understand that context. If you look at Metro Detroit, Arab Americans are not doing very well. There have almost double the proportion of people with less than a high school education, lower proportion of people with college. They do have a lower proportion of people who are unemployed, but a higher proportion of people in poverty, which means people are working, but they're what we call the working poor, right? They're working, but they're barely making a living wage. So that's Metro Detroit. When you compare Arab Americans to blacks and whites in the Metro Detroit area, you also see that there's a lot of disadvantage. I mean, Arab Americans are much more likely to have less than a high school education than blacks or whites. Not too bad with college. I mean, almost at the level of whites, but still less than whites and more than blacks. Less likely to be unemployed, but also the most likely to be living in poverty. And I think many of you may know the well-documented finding about the socioeconomic gradient in health. The lower your socioeconomic status is, the worse your health, right? So we know that Arab Americans are at risk for a lot of health problems. We haven't been able to study it adequately yet. There are community studies that show us a lot about this. And what I hope to show to you today is findings from the Metro Detroit COVID study, which focused only on older adults. It's part of a larger network of projects, and I'll just tell you briefly about it because I'm really excited about the fact that we were able to get funding from the National Institute of Health. I've been trying for over 20 years to get funding from the National Institute of Health, and they kept telling me, well, Arab Americans are so small, what do we care about them? I mean, they're a small population in the US. Why should we put money towards them? They're just like every other immigrant group. You know, there's nothing new you're gonna learn from Arab Americans. We finally made the case in Metro Detroit as to why we need to be able to study Arab Americans. And we have a series of projects that are broadly called the Detroit Area Wellness Network projects. The Detroit Aging and Memory Project is going to focus on Arab Americans explicitly, where we're going to try to recruit. It's actually going in the field the end of May. I'm really excited. It was supposed to go in the field in April of 2020. And guess what happened? COVID stopped everything. And in the meantime, everything got more expensive. So the money that they gave us wasn't enough. So I had to go back to them recently and ask for more money. And thankfully, I think I'm just very grateful that we were studying Alzheimer's, because if it was something else, I don't think we would have gotten the money. We got the money and were able to launch the study in the end of May. And this is going to focus on 600 Arab Americans aged 65 and older and compare them to blacks and whites who are part of a longitudinal panel sample that was funded a long time ago. In the meantime, because we were stopped from COVID, we applied for a supplement to study COVID-19 stress and cognitive health. And that's what I want to report on to you today. What do we know about Arab Americans and cognitive limitations? Not much. This bar is from a project that was carried out by a colleague of mine, Flora Dallow, and colleagues, who looked at the National Health Interview Survey, was only able to look at foreign-born. And there were two questions that asked people to answer whether or not, and by the way, the National Health Interview Survey is only in English, not Arabic, so any of these foreign-born will only be English speakers, so that's another bias. Regardless, they were asked they had to answer one of two questions. Were they limited in any way because they get confused and can't, let's see, it's because they get confused and have problems with memory. And the second was, do they get confused because they have Alzheimer's disease? So she combined those. If they said yes to either one of those, they had cognitive limitations. And what she found was that Arab Americans were, do I have another thing? No. Arab Americans were more likely to say they had cognitive limitations than foreign-born white or U.S.-born whites. This is among people 45 years and older, and it's controlled for age and gender. It's statistically significant. So about 7% of whites compared to almost 10% of foreign-born Arab Americans. We also know that COVID-19 was extremely difficult time for everyone. I mean, if nothing else, COVID-19 probably convinced people that the social determinants of health need to be looked at, because it was clear that what affected the most vulnerable ultimately affected all of us. So during COVID, we never really knew what the rates were by race and ethnicity, among the Arab American community, because the Arab American community is not counted. Flora Dallow went and did another study where she used a name algorithm to identify records in the Michigan Department of Health and Human Services. And she looked at it by age. So 18 to 39, 40 to 59, 60 to 79, 80 plus. In every single age group, Arab Americans were more likely to have contracted COVID. And as a matter of fact, Arab Americans were 2.63 times more likely to have tested positive for COVID-19 compared to non-Hispanic whites. So, we thought, this is a good time to see how is the stress from COVID affecting older adults, especially with the shelter-in-place mandates we had in Michigan. Some of the literature came out to show that COVID-19 stress was multidimensional. There was a qualitative study done by Whitehead and Tarosian in 2021, and they interviewed older adults, and they found a whole list of things that were stressful for them. The top 4 were the restrictions and confinement. They were concern for others, loneliness, an unknown future. Number 14 was fear of contracting the virus. Only numbers 2, which is concern for others, unknown future, and fear of contracting the virus, predicted poor psychological health. So even though there's multiple stresses, there's some elements of stress that have more of an impact than others. So we use the stress process model, which is really important for understanding the social determinants of health, because the stress model emphasizes that socially patterned variations in stressors and resources accumulates over the life course to produce advantage or disadvantage in health. Exposure to stress is not randomly distributed throughout the population. It's highly structured and generally reflects patterns of inequality. Stressors may take many forms, and the consequences may manifest in multiple ways. In this case, we were looking at cognitive health as the outcome. So the goal was to characterize COVID-19 stress type, prevalence, and cognitive health in Metro Detroit among 3 racial ethnic groups. We predicted that Arab Americans and Blacks would be more likely to report stress and worse cognitive health compared to whites. And then we wanted to see if the racial and ethnic differences in the association, if there were racial and ethnic differences in the association between COVID-19 stress and cognitive health. So this just tells you some background about our sample. Can I tell you how hard it is to get older Arab Americans to say yes and to participate in the study? And it was a telephone study. And especially the women, they would say, well, I don't know, I have to talk to my daughter or my son. Can you call me back tomorrow? And the interviewer would say, okay. And the interviewer would call them back tomorrow, and guess what? They wouldn't answer. It was so hard. We even tried this respondent-driven sampling approach where we asked MENA, actually, and Black participants to refer others to the study as a way to try to increase our numbers. It was very difficult. It was only a 30-minute survey. So we have our measures of ethnicity, age, marital status, gender, education. Our COVID-19, we had 3 stress measures. We conceptualize stress as if the older adult or anyone in their household had COVID-19, did they lose someone they knew because of COVID-19? And did you or anyone in your household lose income because of COVID-19? To measure cognitive health, we did a telephone battery. They had to be very, very basic questions. And by the way, everything was translated into Arabic and very carefully translated into Arabic. It took a long time, but we wanted to get it right. We wanted to make sure the meanings were translated as well as the words. So sometimes you use different words to get the same meaning. Nevertheless, we had 4 indicators. We used the CRAD word list. We used language indicator by measuring animal fluency. I'll talk to you a little bit about that. That was really interesting. Doesn't work really well with Arab Americans. We measured attention by having them do the forward digit span that you find on the MOCA, and working memory by doing the MOCA digit backward span. So, as I told you, if you look at, we couldn't get the women to participate. Only 35% of our sample were women. And if you look at the blacks and whites in our sample, they reflected more the population, because I'm sure you all know women live longer than men. And that's true in the Arab American community too. If you look at the American Community Survey data, women outnumber men after 65. But in our sample, they were only a third. So we're working really hard with communities now when we go into the field to try to make it clear why it's so important for women to participate. I mean, when you think about it, cognitive health and Alzheimer's, first of all, 2/3 of all cases of Alzheimer's are women, primarily because they're living longer. But even when it comes to caring for someone with Alzheimer's, who's doing the caring? It's the women. So they stand to benefit most, I would say, from participating in research. It's only through research that we can find out what the strengths are, what the challenges are, and how we address them. So we're trying to get that message out into the community. I want to also point out that the Arab Americans were much more likely to be married. Almost 3/4 of the older adults who participated were married. Only a third of the blacks who participated were married, and a little over half of the whites. And then the Arab Americans had the lower education levels who participated. I mean, still on average more than high school, but nevertheless lower than whites and blacks. Okay, prevalence of COVID-19 stress. Am I supposed to leave time for question and answer? Okay, I'm gonna try to. Pardon?
That would be good, actually.
Okay, I'm gonna try to go through this a little bit more quickly. It's just so much fun to talk about it. Okay, so when you look at the stress levels, the thing to notice here is that basically the Arab Americans reported the highest levels of stress. I mean, they matched the blacks when it came to knowing someone who died from COVID. They were much more, almost twice as likely to say someone that they knew or in their household had COVID or they had COVID. And almost twice as likely as whites to say that they or someone in their household lost income because of COVID. So stress was high among Arab Americans, lowest among whites. And I want you to remember that because that's going to show you something later. One thing I like to do is, Arab Americans are considered white. And what I want to show you here is when we combined the Arab Americans with the white sample, we saw a very different picture. It looked like there was no disparity between whites and blacks when we combined Arabs with whites. Here it looked like whites were doing worse when it came to COVID symptoms. And it didn't mask this disparity. Blacks still reported more death from COVID. But nevertheless, I'd just like to show that point because it's not only that identifying Arab Americans help us to understand better the Arab American health profile, it also helps to make more prominent what the disparities really are. So that I think that's important because when you're able to identify disparities, you can treat them better. So this is just like a structural equation model. I'm not going to go into details here except for to tell you the finding is that these are whites and blacks compared to Arab Americans when it comes to cognitive health. Whites had much better cognitive health than the Arab Americans in our sample. Arab Americans didn't differ from blacks, but they were, whites reported better cognitive health than Arab Americans. And when we looked at stress, what we found is that only for whites did stress influence cognitive health, but it was a benefit. People who reported stress had better cognitive health. And why do we think that's the case? That's why I told you, remember how low their stress is. I think it goes back to that finding in the literature that says just a little bit of stress when you have some resources actually makes you more resilient. It actually makes you age better because you're facing some adversity, but you also have resources behind you. But that adversity makes you a little bit stronger. Now, it may be too early to really tell what effect stress had on cognitive health. So these are very preliminary findings, but I think it's an important finding here because it shows that if you didn't have too much stress, you probably did better cognitively, even if you had a little bit of stress, if that makes sense. I mean, if you had a little bit of stress, it's as long as if you didn't have a lot, that you were doing better. So, summary and discussion, MENA reported more stress, lower cognitive health than whites. They were more similar to the Black experience in Metro Detroit, allowed us to get a more accurate assessment of disparities. Stress predicted cognitive health only for whites, illustrating that a little stress enhances cognitive function. Okay, I'm going to go really quickly through this next one, but I like this study, so I just want to share it with you. I'll try to finish it in 5 minutes. Adapting an Alzheimer's disease caregiver intervention. I'm going to skip that. Okay, so what we wanted to know, we wanted to advance knowledge and practice by breaking new ground, focusing, now when it comes to caring for a family member, usually interventions that are created focus on one caregiver. And we wanted to challenge that model and say we want to focus on families because the reality is when it comes to Alzheimer's, there's more than one person doing the care. There may be one person who's doing a lot of the care, but usually it affects the entire family. And we wanted to maximize the health and quality of life within the Arab American community. So using the Arab American community as a case study to really help everyone. Because Alzheimer's, doesn't just affect Arab Americans, it affects everyone. So we worked with the Alzheimer's Association, we worked with the Arab Community Center for Economic and Social Services to culturally adapt an existing intervention as a way to enhance comfort and acceptance among the Arab American community, and then we evaluated it. So our cultural adaptation included focus group discussions. We modified program content, including the recruitment material. I'm going to show you an example of that. The PowerPoint videos, and we translated everything into Arabic. The way that we started the adaptation is to have focus group discussions with caregivers. And when we had the focus group discussion, we made sure that people brought another family member with them. And we also had one with service providers. And we asked them to talk about what it was like. Can I tell you how hard it was to get caregivers to come to this focus group too? First of all, finding families in the community with Alzheimer's, it wasn't hard. Everybody knew somebody. And everybody knew maybe more than one other family. But getting those people to say, yes, we're caring for someone with Alzheimer's was like pulling teeth. And then once we did find them, it was only through really personal contacts. Like, for example, I had my son's friend who's a physician, really believed in the research, and she had someone she went to college with. She knew that her mother was taking care of her mother. And so it was like through that connection we got her to come. She would have never come otherwise. I had a PhD student whose mother was taking care of her father, and she brought her mom to the focus group discussion. That was the only way I could get it to have the beginning. I mean, we're making a lot of inroads now, but it was a very difficult start. This is just a composition of our focus groups. I can come back to that. The thing that I want to point out is that there were some themes being covered in the focus groups that are universal. This is something that everyone who cares, this is in the literature, there's burnout, there's the need for respite, there's the dealing with challenging behaviors. This is something that our focus group participants talked about too. But our focus group participants also talked about things that were culturally unique, about the importance of national origin, about having people to help them who were from the same background as them. And they would give really, really clear examples about why that was important. They talked about family dynamics and especially related to cooperation, conflict, and issues of control. Control is a big one. They talked about cultural ideals, like what are the expectations about what is your role? And this is where we learned that actually we couldn't even call this a caregiver intervention because family members didn't define themselves as caregivers. They were just being a daughter, or they were just being their wife, or they were just being the husband. They weren't a caregiver. A caregiver is someone you paid to come and take care of your family member. They didn't define themselves as caregivers. And then we also found practical ideas or strategies to try to encourage families to attend this intervention. So I'm not gonna go through this, but I just wanna give you the example of how we adapted some of the recruitment material. So this is the Alzheimer's Association information. And they say it's for middle stage caregivers. So we replaced that and said it was for Arab American families. Because we wanted the family to come to the intervention, we also didn't just want one person as the main caregiver. We wanted to show that it was a family affair. This is actually my father-in-law. He had Alzheimer's. This is my sister-in-law and her 2 kids, and they were at a wedding. And I don't know how it is here in Houston, but in Metro Detroit, weddings happen almost every weekend, and they're a community affair. It's, like you go to a wedding every weekend, and everybody goes, and it's where you see everybody. So we thought it would be a really nice image to show that, they were at a wedding. I don't know if you can tell that, but, they're all dressed up. And that, it's a family taking care of the person living with dementia. So this was the material that we used to advertise the program. We wanted, we piloted it. We finally got 30 families to come through, 60 people. It was very hard, it took almost a year. And this also, by the way, happened during COVID. So all of our sessions were virtual. So that was maybe a blessing in some ways, but also a challenge. A blessing in the sense that people who are caring with someone from Alzheimer's found it accessible. They didn't have to worry about leaving the house or leaving the person they were caring for. They could actually sit there and participate in the intervention. And this is just to show you that we used the Zaret's caregiving burden score. Those who went through the program showed significant decrease in burden. It wasn't a ton, but it was nevertheless decreased. And they also felt more knowledgeable about Alzheimer's. They felt that they learned useful caregiving strategies. We also had a trend effect where family conflict decreased. That was really exciting. So this was an exciting project as well. So I felt it was success in terms of cultural sensitivity. We captured the words, the phrases, and the ideals of the group. We engaged with our community partners as equals. We made the culture visible, whether it was through, everything was translated into Arabic. We made sure that the names and the people who were presented in the materials reflected the community. These little things can be applied across the board to any culture that you want to try to help adapt information for. You've got to let the community see themselves in the material as a first step for them to accept these programs. There's a lot of challenge, stigma and program delivery. We had a hard time attracting families. I had an outreach person who was sort of walking the streets figuratively. She had to do it through social media because it was during COVID, or through her phone contacts. But we did ultimately find 30 families who came through the program. So I'm gonna conclude here. 3, takeaway points I'd like to leave you with. Arab Americans are becoming a distinct racial/ethnic group. I'm using that term interchangeably. And how do we know that? Because there have been, since 1980, there's been a strong movement to find an option for people of Arab ancestry to identify themselves as separate from white. It's been an uphill battle, and it has not been easy. It was supposed to have been on the 2020 decennial census, and at the last minute, they didn't do it. There's a lot of hope it's going to be on the 2030 census, but this is just to show you that this social construction of racial groups and ethnic groups in the US is very powerful, and it has a lot of implications for people's health. I also want to talk about health disparities, that when we disaggregate Arab Americans from whites, we not only see that Arab Americans in some cases are doing worse than whites, but it also allows us to see the disparities that exist between other groups, because Arab Americans aren't lumped in with the whites and skewing that white profile. Finally, I would say that, we need more research on families and care as it relates to the Arab American community, not only for the community, but it actually is a scientific contribution to really advance what we know about health. I just gave you, I didn't get a chance to present data to you about this, but as I mentioned, Arab American, I guess I did present it with the cognitive limitations. Arab American immigrants, their health profiles are not that good. I mean, I suspect it has to do with the reasons that they're coming to this country. They're probably coming here, they're coming from political instability, they're coming from a lot of conflict. So they're probably coming from situations where there were a lot of challenges. And so they came with health problems, I would assume. I don't know that. But that just goes to show you that there is something to be learned from identifying this group separately from the mainstream. I'm going to end there. Thank you.
I was wondering about your COVID-19 study and if or how it factored in employment to the stress factors for the populations that you surveyed. Because, for example, those who had office jobs and could work from home during COVID-19, maybe they didn't have that stress or that loss of income. So did you notice any particular trends tied to employment across the populations that you surveyed, or was that not a factor?
I did look at, I have the data. I have the data where I can see where the jobs are. I haven't looked at that yet, but what I will say is that the Arab Americans had a higher percentage who were working. And these are 65 plus. So these are older adults who are still working, and I do have the information about what kinds of occupations they have in my data set. I just haven't looked at them yet. Actually, we just coded them. So what we do is we ask open-ended questions. We say, what's your occupation? And they tell us, and then we go, we look at the categories in the census, and we categorize them according to that.
In clinical practice, I find that Arab American patients are tough. They under-report symptoms and they over-report symptoms at the same time. Any comments on this? As far as research.
Yeah, as far as research. I haven't done any research on that. I will say that one of the ways that we are trying to convey the importance of participating in research is by appealing to the concern that the community members have about their health and their parents' health. So I know that there's a, you don't have a hard time having Arab Americans come to see you though, I would assume.
No.
Like they come regularly for their annual checkup, right? Like they're ready.
And for their psychiatry visits.
Okay.
But because they report in a different framework and a different paradigm, it's
Yeah.
actually hard to get the information we need.
Yeah. That's a great observation. I don't know much about that, but what I will say actually, now that you're saying that, there is a are you all familiar with the Center for Epidemiological something depression?
Yes.
CESD. I know it by its abbreviation. The way I have that measure with the Arab Americans as well, it doesn't have the same reliability as it does for whites.
Right.
So it's not a good measure of depressive symptoms. I don't know what a good measure would be. I think we need to find one. Actually, it would be great to do a focus group discussion with the CESD and hear how people talk about these different dimensions and see what other dimensions they bring up and probably come up with a scale that's more relevant for the Arab American case. Yes?
Think about your data about the bifurcation, I think you call it, of Arab Americans. Higher proportion with college plus education and higher proportion less than high school. Did you look at any differences between the two groups in terms of the period of time they immigrated or the regions they immigrated from, or any other social or economic determinants of health between them?
I didn't explicitly look at that, but even in the data that I presented today, you can see like in Houston, there is no bifurcation. It's pretty much, it's a well-educated, not a lot of poverty, doing pretty well in the Houston area. In Detroit and nationally, it's very bifurcated. I'm not sure if, to what extent it's linked to immigration wave. What I will say about Michigan is Michigan tends to, the Metro Detroit area and the area where Arab Americans tend to live is very working class. These are working class areas. So I suspect that that has something to do with it, and it's something we can look into. We have the data to do that. Yes?
I think the bifurcation that happens is as someone who, like, I'm an Arab American that grew up overseas and moved here, and what I've noticed is that at least the Houston Arab Americans, or like, they mostly come like, if they're coming to Houston, it's mostly an oil job, or you're a doctor, or so you're a more higher profile jobs. And then I'm assuming like people who have been in like Michigan are people who've been here for like ages. It's not like they just immigrated to the US.
Actually, Michigan has a very large, growing immigrant element to the community, but they also have a lot who are established. You're right. It's an established community, but at the same time, a very immigrant community. And there's sometimes conflict between the U.S. born and the immigrants. But yeah, I think it has to do with what, if you're going to a particular part of the country, what's taking you there? What kind of jobs are available there? And I think I was talking to Rolla earlier, there's the refugee community is growing here in Houston. What we're finding in Michigan is that the refugees who are placed in different parts of the country are voluntarily coming to Michigan because they know there's a community there. And so, refugees come with another host of issues.
One last question? Your last question.
It was very nice listening to your lecture.
Thank you.
I am coming from United Arab Emirates. I just want to know, are the American Arabs here happy people or sad people?
I actually have a question on happiness that I did not analyze. I can analyze it and let you know.
I just want to know because I know in that part.
Are they happy in that part of the
But
world?
here I want to know.
And are they happy in the United Arab Emirates?
Yeah, very happy. Very happy. But here I want to know, are they happy, smiling always or no?
Happiness indicator. Happiness indicator. One of my friends once told me, one doctor, Americans are happy people. Wherever you walk, you see them smiling, happy. We're not like this. That's a good point.
Compared to the Europeans.
Oh, yeah.
Compared to the Europeans,
Yeah.
French,
Frowning.
and Americans always smiling, good morning, good evening.
Well, did you ever notice when you try to take a picture of somebody in an Arab country? They don't smile.
Yes.
But we smile. In America, you're supposed to smile. Smile for your picture.
This is a good question. I'll answer you.
Well, thank you. Thank you very much, Dr. Ajrouch. That was
Thank you.
wonderful. Thank you everyone for coming.